Good evening and Assalamu alaikum. I am Muhammad Azan and I am a student of second year MBBS at Central Park Medical College.
And I'm Abbas Murtaza Jafri, a third year medical student at Central Park Medical College. We're now moving towards our third segment, focused on auto-inflammatory disorders. It gives us great pleasure to introduce Dr. Rafaqat Hamid from the Department of Rheumatology at Central Park Teaching Hospital and Dr. Iftikhar Ejaz, Professor of Pediatrics and Pediatric Nephrology, as the chairs for the third session on Pediatric Rheumatology course.
We are pleased to welcome back Dr. T.Kai Liang, who will now be speaking on auto-inflammatory disorders, diagnosis and management in resource-poor settings. Please join me in welcoming him to the stage.
Okay, a very good evening once again. It's a great pleasure to be here to talk about autoinflammatory disease. And this is the guideline outlined. I'll first talk about how we defined autoinflammatory diseases. There is so many autoinflammatory conditions, how we can classify them. I will give bite-sized information on some of the common autoinflammatory diseases, as well as a practical clinical approach on when to suspect an autoinflammatory disease and how to manage it, especially in a resource-limited setting. So many of us may be familiar with the term autoimmune condition, but may not be so familiar with the term autoinflammatory condition. The term autoinflammation was coined in 1999. Prior to this, cases of FMF as well as TRAPS have already been published in literature. But it was only in 1999 when Dr. McDermott as well as Dr. Kessner came together in their manuscript describing patients with TRAPS. They say that autoantibodies are not a general features of these illnesses, and for this reason, the term autoinflammatory is preferable to autoimmune in describing these disorders. So traditionally, people think of autoimmune condition as a problem with the adaptive immune system and therefore mediated by autoantibodies, whereas autoinflammatory conditions are due to problem with the innate immune system and therefore cytokine driven. But we now know that this is no longer so true. People see immune-mediated disease as a continuum. On one end of the spectrum, you have monogenic autoinflammatory conditions like FMF as well as TRAPS. And then you have autoinflammatory conditions that are polygenic, for example, IBD as well as Still's disease. In between, you have the mixed pattern diseases like psoriasis and Behçet's. You have polygenic autoimmune conditions like lupus. And lastly, on the final end, you have autoimmune diseases that are monogenic, like autoimmune lymphoproliferative syndrome. Autoinflammatory condition as well as autoimmune condition shares many similarities and differences. In terms of etiology, a lot more autoinflammatory conditions are monogenic in nature, whereas autoimmune conditions are mostly polygenic. We talk about the immunological difference. Autoimmunity is due to problems of the adaptive immune system and therefore a lot of self-reactive lymphocytes as well as autoantibodies, whereas autoinflammation is more cytokine driven. And because of these genetic differences, in terms of autoinflammatory condition, there is a younger age of onset, more pediatric, whereas autoimmune condition is a lot more common in adults. Both autoinflammatory conditions and autoimmune conditions share many variable systemic manifestations. But in terms of tests, the yield of genetic testing is much higher in autoinflammatory condition compared to autoimmune condition. Both autoinflammatory conditions and autoimmune conditions may have response to a lot of the different biological products, but colchicine, IL-1 blockage, and JAK inhibitors have a lot more role in autoinflammation, whereas autoimmune conditions have a lot more conventional demand options. So the classical case, the stereotypical autoinflammatory case is one with early onset, with unprovoked recurrent febrile episodes, with multi-system involvement, and the patient is completely well in between these episodes, and there is no evidence of pathogenic autoantibodies. But there is an increasing number of autoinflammatory diseases being identified with the use of genetic tests, and many of these new autoinflammatory conditions identified no longer follow that classical pattern. To understand autoinflammatory conditions, we need to understand the immune pathway, and this is the immune pathway simplified. First, you have inducers like infection, tissue damage, which are then sensed by the components of immune system. They release mediators in the form of cytokines, which then goes on to target tissues and cause inflammation. But the immune system is really not so simple. There are various components of the immune system, as well as a lot of crosstalks between the components. But in general, problems can happen in three different areas. One, the pattern recognition receptors, 2, the signal transduction molecules, as well as 3, intracellular effectors, and all these will then result in abnormal cytokine production. Because of the crosstalks of different immune components, auto-inflammatory conditions also have features of other immune dysregulatory disorders. For example, immunodeficiency, atopy, as well as lymphoproliferation. Auto-inflammatory diseases also have variable multisystem presentation as well as fever pattern. So listed here are 4 classical auto-inflammatory conditions, and you can see that their fever pattern as well as the organ manifestations are all very different. Now, even within a single auto-inflammatory condition, like for example, cryopyrin-associated periodic syndrome, there is variability in terms of the disease presentation. So they can present as a milder form, like familiar cold-induced autoinflammatory syndrome, where patients just have cold-induced rash, urticarial rash, or they can present as a more severe spectrum in the form of NOMID, where patients have severe neurological manifestations. This heterogeneity also extends to the prevalence of autoinflammatory conditions according to the geographic location. For example, look at the Euro Fever Registry, which captures autoinflammatory conditions in the European countries. They have a lot more FMF and TREPS, and followed by the polygenic causes like PFAPA. Whereas closer to us in the Indian registry, they have a lot more Blau syndrome as well as hyper-IgD syndrome, as opposed to FMF as well as TREPS. So, why is it important for the adult rheumatologist to know about a condition that mostly has a childhood onset? Because autoinflammatory conditions are increasingly recognized and treated, children with autoinflammatory disease will eventually reach adulthood. 2, there are still a lot of diagnostic delay as well as missed cases in childhood, so a lot of these patients will still go to the adult rheumatologist with persistent symptoms and signs. And there is also a group of patients that may be asymptomatic in childhood and may only express symptomatically in adulthood. So that is an overview of autoinflammatory condition. We are now going to look at how we can classify these autoinflammatory conditions. Now, I mentioned that defects along the inflammatory pathway can result in autoinflammatory diseases, and the key players are interleukin-1, IL-18, type 1 interferons, NF-kappa B, tumor necrosis factors, as well as immune modifiers. There is no consensus way of classifying these autoinflammatory conditions, but most of the literature will classify them according to whether it is an issue with inflammasomes, whether it is an issue with the type 1 interferon, whether it is a problem with the NF-kappa B pathway, whether it is due to enzyme deficiencies, or whether it is an issue with cytoskeletons. And we will now look at each individual categories in a little bit more detail. Starting with inflammasomes. So inflammasomes are multimeric protein complexes, and the formation is mediated by multiple genes. They primarily act as immune sensors, and ultimately their aim is to activate caspase-1, which then cleave pro-IL-1 beta as well as IL-18 into the active form of IL-1 beta as well as IL-18. So you can see that any problem with the inflammasome formation can result in overproduction of these cytokines. Some characteristics of inflammasopathies: recurrent fevers, patients get neutrophilic rashes, arthritis, serositis, and it is predominantly IL-1 mediated, but when IL-18 is involved, patients can also present with macrophage activation syndrome. These are some of the common inflammasopathies that are listed here, and I will just give bite-sized information on some of these conditions because it is impossible to cover all of them within a span of 30 minutes. First, starting off with familiar Mediterranean fever, it is due to a gene mutation in the MEFV gene, and fever lasts classically 1 to 3 days, and the hallmark of FMF is serositis, when patients can present with chest pain as well as abdominal pain. They can also get arthritis and variable skin manifestation, but the classical skin manifestation is erysipelas, where they can get this cellulitis looking like picture. PAPA stands for pyogenic arthritis, pyoderma gangrenosum, as well as acne. It is an autosomal dominant skin disease, but patients can have extracutaneous manifestation. And as the name suggests, the classical rash is pyoderma gangrenosum, which starts off with nodules and they will eventually ulcerate. Hyper-IgD syndrome is due to mutation in the MVK gene. It presents as a spectrum of condition. The milder form is mevalonic aciduria, and hyper-IgD is the more severe form. Patients can have recurrent fever, joint pain, aphthous stomatitis, And skin rashes, again, can be quite variable from maculopapular rash, non-migratory rash, and may be painful. Patients also get hepatosplenomegaly as well as lymphadenopathy. And in fact, in recent literature, there is a described association with hidradenitis suppurativa, as in this case report over here, with hyper-IgD syndrome. CAPS, cryopyrin-associated periodic syndrome, it is inherited in autosomal dominant fashion. I mentioned that it has a spectrum of manifestation, the milder one being a familial cold autoinflammatory syndrome, and a more severe nomid presentation. It is characterized by self-limiting recurrent fever, arthralgia, and urticaria-like skin rashes on exposure to cold, but more severe neurological involvement includes sensorineural hearing loss and chronic aseptic meningitis, and patients may also get skeletal abnormalities. So those are the inflammatopaths, and you will realize that the inflammatopaths really follow the classical pattern as what was described previously. The recurrent fever, patients get neutrophilic dermatosis as well as arthritis. The subsequent few categories no longer follow that classical stereotypical autoinflammatory conditions. We first talk about the type 1 interferonopathies. Type 1 interferons is really important in the human body. They can have protective effects like protection of epithelial barrier, clearance of pathogens, as well as protective cytokine production. But it can be detrimental when there is overproduction, leading in cell death as well as pro-inflammatory response. So type 1 interferonopathies can result as mutations in genes regulating sensing and processing of nucleic acid. So the abnormal accumulation of this nucleic acid can then stimulate type 1 interferon response genes to produce type 1 interferons. The other pathways is mutation in genes regulating the proteasomes over on the left side. And again, that leads to stimulation of the interferon gene and overproduction of type 1 interferons. I mentioned type 1 interferons during my talk with lupus, so type 1 interferonopathies present with a lot of autoimmune features and lupus-like symptoms, such as panniculitis, lipodystrophy, and leukocytoclastic vasculitis. The classical type 1 interferonopathies also may get interstitial lung disease as well as intracranial calcifications, and CRPs may not be elevated during acute attacks as compared to inflammatopaths. Listed here are some of the common interferonopathies, and I think Aicardi-Goutieres syndrome is probably the most common among all. It is a heterogeneous group of disease with 7 different genes associated. It can present as a neonatal form with hepatosplenomegaly, thrombocytopenia, and microcephaly, much like a torch infection. There's an early infantile form with neurological impairment and encephalopathy, with a CT brain showing intracranial calcification, and a later onset form which tends to be milder with less neurological involvement. But regardless of when is the presentation, they may get skin manifestations such as chilblain lesions, livido, nodules, as well as Raynaud's phenomenon, so a lot of vasculopathic manifestations. SAVI stands for STING1-associated vasculopathy of infantile onset, and it is characterized by recurrent febrile episodes. The skin manifestations include acrofacial cutaneous vasculitis with tissue loss, chilblain lesions, and lividoid rash. And classically, they also get interstitial lung disease, such as this CT scan showing a lot of ground glass changes. And PRAS, or proteasome-related autoinflammatory syndrome, again presents as a spectrum of condition, but CANDLE being the most classical. And CANDLE stands for cutaneous atypical neutrophilic dermatosis with lipodystrophy and elevated temperature. And the name suggests that these are the manifestations like lipodystrophy. They get nodular neutrophilic dermatosis, hepatosplenomegaly. They also get intracranial calcification, but it tends to be in the basal ganglion region, and they also get ocular manifestation. So moving on to NF-kappa B pathway, it is a family of protein complexes that act as transcription factors, regulating genes involved in inflammation, immunity, cell growth, and survival. What it does is that it translocates into nucleus to drive pro-inflammatory gene expression. And the NF-kappa B-opathies present a lot with mucocutaneous ulcerations, arthritis, GI involvement, and uveitis, and some of them also get immune deficiencies. So listed here are some of the common ones, including haploinsufficient of A20, which was just recently gained increasing recognition over the past few years. But I want to make special mention on Blount syndrome since it is common in the Indian population. It is due to mutation in the NOT2 gene, and patients present like a sarcoid case with a lot of granulomatous dermatitis, granulomatous arthritis. So on examination, you get this very boggy looking arthritis as well as uveitis. TREPS, tumor necrosis-related associated periodic syndrome. A fever classically lasts 1 to 4 weeks with migratory erythematous macules, but classically they get this periorbital inflammation and pseudocellulitis, along with abdominal pain as one of the prominent symptoms. There can also be problems with cytoskeletons. Cytoskeletons are crucial in leukocyte mobility and phagocytosis and really forming the immune synapse so that the different components of the immune cells can crosstalk with each other. And mutations in genes that regulate actin cytoskeletons can also cause inflammation. And we call these actinopathies. A lot of the actinopathies overlap with the inflammatories like PAPA and FMF, but a lot of the actinopathies are also immunodeficiency conditions like Visco-Eldridge as well as Dog8 deficiency. Key manifestations are like cytopenias, cutaneous lesion, lymphadenopathy, hepatosplenomegaly, so it really behaves like a primary immunodeficiency condition. You also can have problems with enzyme deficiency, and of course I want to make special mention with adenosine deaminase 2 deficiency, DADA2. Due to mutation in the CACR1 gene, patients can have 3 main manifestations where you can present with vasculopathy, with stroke, polyarteritis nodosa, and they can get this livedoid-looking rash, hematologic involvement with cytopenia and lymphoproliferation, and it can also get immunodeficiency with hypogammaglobulinemia. Apart from these inherited monogenic autoinflammatory conditions, there are also monogenic autoinflammatory diseases with somatic mutation, meaning that they only acquired it on later and are not inherited. And some of these have mosaicism patterns, so they have an adult presentation. And the most classical described one is the gene mutation in the UBA1 gene for VEXAS syndrome, stands for vacuoles, E1 enzymes, X-linked, autoinflammatory somatic syndrome with a lot of variable systemic manifestations. Other than monogenic autoinflammatory disease, you also get polygenic autoinflammatory disease like Still's disease, PFAPA, Behçet's, chronic non-bacterial osteomyelitis, as well as gout. And these conditions are now being recognized as autoinflammatory disease, where they used to be called autoimmune conditions. A special mention on PFAPA because one of the common presentation to a pediatrician or a family physician is recurrent oral ulcers. And PFAPA stands for periodic fever, aphthous stomatitis, pharyngitis, and adenitis. The onset is usually between age 2 to 5. Fever starts suddenly and lasts for 3 to 7 days. And episodes may occur every 3 to 6 weeks, and patients is completely well between these episodes. So, I went through so many different autoinflammatory conditions and different categories. I hope we are not feeling too overwhelmed now. So with so many autoinflammatory conditions, how can we approach them? First, when do we suspect autoinflammatory condition? When there is recurrent episodes of systemic inflammation, when patients present with periodic fever, elevated acute phase reactant, although not always, and variable systemic clinical manifestations. They can have positive family history and consanguinity, when the disease onset is early, and when symptoms generally respond poorly to standard of care. I want to emphasize that absence of fever does not rule out autoinflammatory condition because you can see a lot of these autoinflammatory conditions do not have fever. For example, DADA2, they present as more of a recurrent stroke episode rather than recurrent fever. Of course, in terms of pertinent history, you want to look about onset of symptoms, really find out their fever pattern and interval. And I just want to emphasize that sometimes for autoinflammatory condition, you need to take a very detailed history into each manifestation and to tease out that pattern because they comes in with different variable systemic manifestation, and sometimes it's very difficult for the patient or the parents to describe them. The fever diary really helps because some of these classical fever patterns have been described in literature. For example, in FMF, you get a classical sudden rise in temperature and sudden drop from 1 to 3 days, whereas in TREPS, you get an intermittent fever that can last 2 to 3 weeks. You will do a head-to-toe examination, but I would say that pay special attention to cutaneous manifestations since a lot of autoinflammatory conditions have cutaneous manifestations. But the other systems that are commonly involved are like neurological uveitis, serositis, GI involvement, interstitial lung disease, as well as sterile bone disease. So in terms of workup, I would first do an infective and malignancy workup to rule out these conditions. Then I will do inflammatory markers and full blood count, liver renal function, both when the patient is well and during attacks to establish the pattern. You want to do tests to look for organ involvement, like for example, cytopenias and stool calprotectin. Imaging sometimes may be helpful, for example, MRI brain to look for intracranial calcification, eye examination to look for uveitis, and really biopsy, especially skin biopsy, which can help characterize the pathway that we are looking at. And of course, if there is resources to do so, then cytokine panels, functional assays, and interferon gene signature really helps to delineate the pathways involved. So this is the table, okay, that shows all the different manifestations across some of the common autoinflammatory conditions that I mentioned just now. And you can see that there's really no fixed pattern to each different category. But as a general rule, okay, for me to really give some pointers and pearls on how we can think about certain categories, the green ones are inflammatopaths. They tend to present as a classical case of periodic fever, neutrophilic rash, as well as arthritis. The orange ones, the interferonopathies, tend to present like a lupus patient. Okay, so lupus-like symptoms, vasculitis, neurological involvement, and low CRP during attacks. The blue one, problems with the NF-kappa B pathways, they get a lot of IBD symptoms and Behçet's symptoms, so a lot of oral ulcers, GI involvement, uveitis, whereas the cytoskeleton problems present a lot of immunodeficiency. So this is a rough guideline for you to know how to classify them when you come across a patient with suspected autoinflammatory condition. Skin biopsy is really helpful because it can help to classify the autoinflammatory condition. You want to see whether the skin biopsy is more neutrophilic, vasculitic, or granulomatous, and then it can help classify different categories. So to summarize the clinical approach, first, look for features suggestive of autoinflammatory disease. Then look for associated features with other immune dysregulatory conditions like immunodeficiency, atopy, and lymphoproliferation. You want to rule out differentials with infective workup and malignancy. You want to find inflammation and organ involvement and establish that pattern when the patient is well and when the patient is sick. You want to classify them, whether it follows a classical autoinflammatory condition or monogenic cause, or whether this is polygenic. And lastly, to clinch the definitive diagnosis, then genetic tests and functional assay. Now, I mentioned about genetic tests, but I want to emphasize that genetic tests is not the answer to everything. There are a lot of caveats when looking at genetic tests. Number one, many genes are still undiscovered. Number two, there can be polygenic systemic autoinflammatory diseases that do not have a single gene mutation. And in order for you to establish that pathway, you need to do functional analysis. But unfortunately, timeline for functional analysis is much slower than gene discovery. So even if you have a single gene mutation, sometimes you do not know whether this is causation or an association. In fact, a lot of times you do not need the genetic test to diagnose a patient with autoinflammatory condition. This is the Eurofever and Printo clinical classification for some of the common autoinflammatory condition. You can see that without genetic tests, they look at variable systemic manifestation with really good sensitivity and specificity. I won't go through in detail, but this is a good read to see how they can diagnose patients with autoinflammatory condition without using genetic tests. If you do send genetic tests, then there are several centers worldwide that can help to do these tests. We tend to send our genes for in vitro testing because they really have a lot of genes that are tested and the price is really not as high as other labs. Just a special note that they do not test the UBA1 gene, so VEXAS syndrome is not included in the autoinflammatory panel. The management is really dependent on the underlying cause. In general, first-line treatment includes NSAIDs, steroids, and colchicine. And second line includes biologic DMARDs and JAK inhibitors because a lot of them actually don't respond that well to conventional DMARDs. You also want to do organ-specific treatment, like for example, if renal involvement, then whether renal protective medication, and important to prevent disease activity and complications by screening for amyloidosis and optimize growth and nutrition. So going through some of these medication, colchicine is well established for FMF as well as PFAPA. Anti-IL-1 has a lot of role in terms of the inflammatopaths, hyper-IgD, as well as TRAPS. In fact, FDA has approved canakinumab for use of these three rare conditions. Anti-IL-6 tend to perform better in the polygenic autoinflammatory conditions like Castleman's disease, Still's disease, but also has a role in VEXAS syndrome. Anti-TNF for the NF-kappa Bopathies and DADA2. The JAK inhibitors, especially for interferonopathies as well as VEXAS. And I put a question mark for anifrolumab because it is still not approved for use in children, but definitely a lot of role in terms of interferonopathies. Now, it is also important to monitor the disease activity, but so far there are no validated tools to do so. This is just one of the examples on how you can take a diary in terms of the various manifestations and trend it during the process. And I also want to make a note in terms of the disease impact. Okay, so you can see on the bottom, the quality of life score during flares is really low. But even in between attacks when the patient is well, the quality of life score improved, but is not perfect, suggesting that patients may still have some residual symptoms during in between the attacks. In fact, when they look at self-reported impact of auto-inflammatory condition on quality of life, 3 big domains come up: fatigue and pain, anxiety about disease flare, as well as financial concerns. So as doctors treating auto-inflammatory conditions, we really also need to take care of this. I want to end off with 2 case studies to really highlight all the points that I've mentioned earlier on. Case 1 is a 5-year-old Indian boy with recurrent febrile episodes associated with intermittent urticaria-like rash, polyarthritis, and recurrent diarrhea. So this very periodic nature. Parents are non-consanguineous, there's no significant family history, and on examination, patient is well thrived, other than the arthritis is otherwise unremarkable. The CRP is not really fantastically high, but patients does exhibit features of chronic inflammation with iron-deficient anemia as well as thrombocytosis. The rest of the workup was negative, and the impression then was whether this is systemic GIA versus autoinflammatory disease. Now, this case really highlights one of the challenge because a lot of these autoinflammatory conditions, the fever can rise on its own. Okay, so sometimes when you admit the patient for inpatient, the fever goes away and gives a false reassurance that the patient is now well. And patients are well in between the episodes, so sometimes they may default follow-up because they do not think that they are unwell. The patient is readmitted at 7 years old, again, for the past few years, has got this recurrent fever, joint pain, loose stools, rash almost every month. And now we managed to capture that high CRP during the attacks with ultrasound abdomen showing bowel wall thickening. So if you look at the fever pattern when the patient is admitted to the hospital, it really resembles one of the fever pattern that I talked about just now. Because of this periodic nature, because of this arthritis and rash, we thought about inflammatories and specifically hyper-IgD syndrome. Interestingly, the patient's IgD level is not high and the urine did not show any mevalonic aciduria. So sometimes without genetic tests, it is quite difficult to make a diagnosis, and it's only when we send the genetic test that the gene came back positive for the MVK mutation and patient was started on anakinra. Case number 2 is a 16-year-old Malay boy who presented at the age of 11 with optic blurring of vision with MRI orbit and brain, showing left optic nerve perineuritis as well as inferior rectus myositis, and the ANA was more than 1 in 800. So remember I said that autoinflammatory conditions usually do not have any autoantibodies. So we treated this as sort of like an autoimmune condition with methotrexate, and this is the MRI finding showing the periorbital myositis. But 4 years later, the patient presents with a stroke episode. The MRI brain did not show any vasculopathy. The patient subsequently had another episode of stroke, and this time round, the MRI brain showed a couple of arterially enhancing blind ending tubular structures that seems to resemble aneurysm. And true enough, when we did a 4-vessel angiogram, they showed the presence of aneurysm. Okay, and the arrow shows these tubular-looking structures, which are actually aneurysms. Now, because of hypertension, we also went on to do renal imaging, and patient eventually had a renal angiogram, which showed these bead-like structures in the kidney. So the combination of these aneurysms made us thought about polyarthritis nodosa, and because of the recurrent nature, then we thought whether there could be an underlying autoinflammatory condition. The patient also has this livedoid-looking rash, so the condition that we suspected was DADA2. And indeed, we sent out the ADA2 gene, which showed the mutation, and there is also correspondingly low ADA2 enzyme activity. So the take-home message, there must be a high index of suspicion in patients with recurrent and unexplained fever episodes without clear infection source or autoimmunity. Patients with autoinflammatory conditions have variable severity as well as a wide phenotypic range. The main categories of signs and symptoms include mucocutaneous, eye, GI involvement, musculoskeletal involvement, cardiopulmonary involvement, as well as neurological. And the available treatments include colchicine, biologics, JAK inhibitors. And I want to stress that in resource-limited setting, when you really cannot send genetic tests, sometimes you just have to go ahead and start empirical treatment based on what you think the patient most likely classify and monitor for the response. And with that, I end my presentation and we'll be happy to take any questions.
We now move into the question and answer segment for this session. We request that our chairpersons to kindly lead the discussion, moderate the flow of questions, and direct them to our speakers for their valuable insights.
Thank you very much, Dr. Tech, and absolutely wonderful session. And you have elaborated everything related to inflammatories. I just wanted to invite questions from the audience, if any, please. I haven't received so far any questions. And for my own interest, I would like to ask that we are dependent on genetic studies, which obviously is a challenge in lower middle income countries like Pakistan. And we cannot really pinpoint because there's so much mimicry in symptomatology of various conditions. Sometimes it is difficult to pinpoint. Secondly, like in lupus, whatever we treat and even in advanced centers, mainly the data has been extrapolated from the adult studies, and we hardly have any concrete evidence on the pediatric RCTs. Similarly, hold true for all the drug levels. If we talk about mycophenolate mofetil, we actually extrapolate the maximum dose from the adult studies, and we haven't yet achieved that target that where we need to keep it. So obviously, we do expect various side effects related to maybe higher levels and kind of things. So what should be the forward further plans? I mean, you people are here, and I would request with the from this forum that from the Asia Pacific we should have a collaborative randomized controlled trials and studies, especially in pediatric population, because obviously my interest is more toward pediatric, being a pediatrician and pediatric nephrologist. So number one, we need to have a collaborative studies to come up with a concrete evidence for the pediatric population.
Yeah, I think firstly, a lot of attention is being paid to the adult rheumatology world, mainly because a lot more conditions. But in order for childhood onset rheumatic conditions to gain that recognition, I think the various countries in that region must really come together. First, maybe to establish the registry and really put the information out there describing our childhood onset rheumatic conditions, that it is really different from adult onset rheumatic conditions. And with that increasing recognition, then there is a push for more trials to be done specifically for children, as well as further research to be done for children. The first step is always just to increase that recognition that childhood onset rheumatic conditions cannot use extrapolated information from adult trials. And that is really the key limitation so far. We need to put this information out there in order for us to push forward further research agendas. Prof. Tesh, you have anything to say?
So you touch on the MMF cell set. Normally we use 30 to 50 milligram per kilo and the maximum 2 gram. The moment that we use more than that, cytopenia come. But then we hardly measure the level unless I suspect compliance, whether you take it or not. Then that's the one. JIA is easier and it's more common. So the apply in Asia Pacific region, we already did finish what I just presented the last session. Lupus is in the pipeline because there are many features. However, in order to do the clinical trial, right, randomized RCT, randomized control trial in pediatric, even pediatric lupus, even though Asia Pacific, we have a lot of patients there. You can get easily 1,000 to 3,000 in your pile, but then every single country is not easy for them to do it, unless it's fully sponsored, which all the drugs that we look at is usually once they do in adult nowadays, FDA actually approved to extrapolate if the pharmacokinetic study is there. So they shorten that. That's a good example for the anifrolumab. That will be approved soon, I guess. Yeah. But other than that, even in the US, do randomized control is not easy, and then it takes time. And then it take a lot of resource. They shy away and then do consensus treatment plan. Meaning they use statistic mean to get it off or balance the confounder, but they have consensus treatment plan, meaning the expert get together with evidence base and then protocol number one, you do this, number two, do this, number three, do this. And that is the way to go nowadays in this rare disease and quite severe disease. There's no other way to do randomize that easily. And those usually take 3 to 5 years to finish even. So that's our opinion here. And in APLA region, because we are shortage of pediatric rheumatologists, research-wise is like not the first priority other than get rid of the patient bad outcome first. So that is the first priority before even research. In order, we try to produce more pediatric rheumatologists because that would be the leader in their own country and produce even more. Once we have more, it may be easier to do good research. I hope I answer. Yep.
Yes. Dr. Liang, what a great presentation. You have absolutely and comprehensively covered all aspects of autoinflammatory syndromes, and I think that's why we didn't receive any question from the audience. So I just need to highlight a few points, just a comment. It means that the problem here in resource-constrained countries is that these autoinflammatory syndromes usually remain underdiagnosed and under-recognized due to limited awareness and restricted access to genetic testing. And the biggest problem is overlapping infectious and autoimmune presentations, which is a big challenge. So we have learned a lot from you that even in resource-limited settings, early recognition and empirical treatment guided by clinical patterns can transfer outcomes. So I think this is the take-home message, and we are really thankful to you. Such a great talk by you. Thank you, and we can we conclude this session here? Any questions from anyone?
Thank you to our speakers and the audience for this engaging exchange. Thank you so much.
Now I would like to request Professor Nigat Mir Ahmed, Patron-in-Chief, Professor Sumaira Farman Raja, Chair Scientific Committee, and Dr. Raza Jafri to present a token of appreciation to the chairs of this session.
What a fantastic session. Honestly, glued to the chairs, listening, look at the fellows, trainees, pediatricians. Thank you so much. Thank you so much, Sumaira, for doing all this. And thank you, APLAR, and thank you, PSR. I think it was so enlightening. Honestly, I haven't left this room, but just for the breaks to where, breaks would be. Fantastic. Loved it. And thanks. Thank you for doing it.
Dr. Iftikhar Ijaz. Dr. Rafakat Hamid.